It's not a nice to have, it's essential.
And people need to have the whole range of building blocks in order to be healthy and fulfilled.
Because mental health, it's not simple, is it? It's not like you've been diagnosed with depression, therefore we know that you need 10 days inpatient care and a course of antidepressants and then you'll be better. We know it's just not as simple as that. We're all a little bit different and that's cool.
Asking people that have been affected by those kind of issues about their experiences, about their views, their preferences, and involving them in making the changes is going to make things better for everybody.
Stereotyped assumptions and stigma, they destroy trauma-informed care.
It's not the thing that happened, but it's the sense that somebody made of it.
That person is the expert.
We have to watch out sometimes, don't we? There's services that don't come with a certain kind of arrogance that we know best and we know what the solution is. And being safe is always the number one.
And as I mentioned about intersectionality, it all comes together to present that individual in front of you who's a very complex person before they even start to discuss what the help they need.
Hi, I'm Nikki. I work in a lived experience role and I've been involved in the trauma-informed organisational approach.
Hi, I'm John Duncan. I'm the Equality, Diversity and Inclusion Lead for the Trust, and obviously that links in with a lot of trauma-informed work.
Hi, I'm Sarah and I lead work on health inequalities for the Trust.
And I'm Alex. I'm a psychologist most days, but I also spend a day a week working on the Culture of Care project for the Trust. So I've got a question, I think, from me first to you, Nikki, if that's all right. So as a staff member, so thinking about as a psychologist or if I was a nurse in one of our teams, what small things could I do differently tomorrow that would help somebody feel safe and heard?
Okay. I think there's probably lots of different things that I think staff could probably take away from this conversation with some small kind of tips and advice to improve kind of that trauma-informed approach to working with people. So I guess for me, one of the really important things to think about is that we're all products of the experiences that we've been through in our lives. So everybody that we come into contact with kind of during the day, whether that's our colleagues or people that we're working with, have all been through things that have kind of led them to the point that they're at. And those things will have impacted on kind of how they are as people and their responses to things, their thoughts, their feelings, how they interact with others. So I think kind of bearing that in mind is always a really good first step. And I think for me, kind of being trauma-informed at its core is just thinking about understanding why. So for me, one of the really important things is not just taking people at face value and kind of how they respond, how they interact, how they think, but seeking to understand kind of what's going on for that person underneath that. So I guess thinking about that idea of everybody being a product of kind of things that they've been through, for me, it's kind of digging into that why. So understanding what happened to somebody and not just kind of what's wrong with them. I think for me, thinking about kind of some of my own experiences, there's some kind of other things that I might suggest as well. So for me, a really big one is just giving people time and space. And I think that's not always easy in kind of the jobs that we do and being busy, having big caseloads. But I think for me, giving people time, so time to share about things as they want to share them. So going at that person's pace, giving them the space to be able to share things that they want to share, I think is really important. I think thinking about environments is also really important when we're working with people. And I think that's kind of probably from a few different perspectives. So thinking about kind of the physical environment that you're meeting with somebody in, being aware of kind of, where you're sitting in a room compared to other people. But I think it's also about kind of sensory input in a room. So people might get overwhelmed more easily. I think, again, if we consider that different people have different experiences, everybody's different, just thinking with that person, what would help them feel safe in that environment. And I think as well, if we're thinking about people sharing things in their lives that might have been really difficult, it's really important to, be in a space that feels safe, that feels comfortable, where people don't feel that they're worried about being overheard, for example. So I think, for me, environments is something to think about. And I guess approaching kind of conversations with people in a way that is creative or flexible is also something that could be really important. So thinking about sitting in a room with someone, I think we know kind of a lot of kind of clinical spaces are very bland, and often kind of sitting face to face with someone, making eye contact can be quite overwhelming if you're expecting someone to kind of share about things that have been really difficult for them. So I think almost thinking a little bit outside the box, being creative where possible, being really flexible in kind of how people want to share with you is really important. And I guess relationships to me are one of the biggest factors. So not expecting somebody to share their life story with you the first time you meet them, that for a lot of people, it will take time. People need to kind of go at a pace that's comfortable for them. And so focusing on building trusting relationships, I think is really important. And doing that in a really collaborative way. I think if we think about people that have maybe experienced trauma or kind of really difficult events in their lives, they might have had experiences of having some of that power taken away from them. And so I think kind of sometimes those kind of clinician-client kind of interactions really amplify that kind of power imbalance. So I think coming together as equals where possible, so seeing yourself as a collaborator and not an authority is really important.
Wow. That's really nice to hear in terms of that's such a good description of what it means to be trauma-informed.
Yeah.
I suppose I was thinking about it, how it applies across a lot of the different services that we deliver as an organisation. So we do a lot of mental health work, but we also have like physical health community services. And I think from what you're saying that it feels like it fits more naturally in a mental health setting when you're spending a lot more time getting to know somebody and you're explicitly exploring some of that trauma and people's circumstances. But I think it can be more challenging sometimes if you're in that physical health scenario where somebody's coming through quite quickly and there's a lot of pressure just to sort of see them and treat them, to create that space for understanding is equally as important in those physical health settings as the mental health settings, because people often have traumatic experiences of healthcare and will feel very nervous going into that setting too. So I think it's just something to think about how it applies across all our services as well.
I think as well there was what you articulated there, I think really applies well to staff as well.
Yeah.
And obviously Trauma Informed looks at the patient journey and those patient things, but also for our staff, not only those who have their own traumas triggered by some of the work they're doing, but often even when we think about our corporate services, of that reducing avoidable harm in investigations and how investigations can trigger trauma due to the very nature of the conversations and the questions that are being asked. So it shows how broad it is as a subject, doesn't it?
I think if we're considering being kind of truly trauma informed as an organisation, it isn't just about kind of that care that we're offering to people that come to us for support. I think you're right that it covers everything. It's how staff interact with each other, how managers interact with people that they work with, how the organisation as a whole kind of all comes together. And I think for me, if we're truly trauma informed as an organisation, that's at all levels. Everybody has a role in that. It's everybody's responsibility to understand that people come with their own different experiences. Everybody's been through different things in their life, whether that's kind of trauma or not. And just that understanding, that curiosity about people and their journeys and how that impacts on how they are in the present, I think is really important.
And I think that core element of it's not a nice to have, it's essential.
Yes.
That we go, but people will be fear that they get things wrong.
Yeah.
But nobody's ever going to complain when someone tries. And they make an effort to listen, to be empathetic, to try and understand how their approaches to something can trigger trauma.
I think at its heart, kind of that just being curious it's a really simple thing, and actually it makes a really big difference. I think just being curious about someone's experiences, about how that might kind of impact on how they're presenting in the moment, is just a huge thing. And I think for me, it kind of boils down to just treating people as people. And that being just a really kind of core takeaway that everybody has had experiences in their lives. People will have had different experiences, but all of that just impacts on the people sitting in front of you. And I think if we can just kind of bear that in mind and do a little bit of that kind of being curious and seeking to understand, I think that is a huge thing.
I really like the word curious in relation to this whole suite of topics. When I'm doing work on health inequalities, we're often talking about structural differences that people have experienced, such as structural inequalities in people's lives. And I think sometimes we assume that people are like us, but unless you're curious about where they've come from, whether they're experiencing poverty, whether they're experiencing racism, and what impact that has on them, I don't think you then understand the full person, because if we make an assumption that when the person we're treating has somewhere safe and warm and not damp and mouldy to go back to and to continue their treatment or continue their psychological work, we don't really understand how they can respond to the treatment and support that we're trying to give them. Mm-hmm. So I think it is about thinking about some of the structural differences as well as the individual differences in the groups of people we support.
Yeah. I think there's something as well about, you were talking about people coming into physical health settings where they might not be that time to get to know somebody's background and understand all of the nuances of what's made them who they are. But that being curious is still really important, even if it's just in your head, to think about, why is this person behaving this way? What might be triggering this? And it might be things that we can't see or we might not know, but if we just imagine what their life might be like, what stresses that are going on for them in the here and now and what they might have experienced previously, that just might give us a little insight as to why are they doing this thing right here and right now? And what might they need from me to feel safe and okay, to be able to engage in the kind of support that we're providing.
I often come back to the words about the building blocks of health, and people need to have the whole range of building blocks in order to be healthy and fulfilled, and in order to recover from whatever they've come to us with, whether that's a mental illness or whether it's a physical illness. That a lot of these factors that affect recovery are things like having secure relationships in your life, having maybe secure employment and a sense of purpose, having safe and warm housing, having a society that accepts you for who you are and doesn't discriminate against you. And if people don't have that in place, then it impacts on what we can do in our roles.
Yeah. But I think it takes people thinking about all those things, doesn't it? It's not just assuming the person in front of you might not have experienced any of those things. I think it comes back to being curious, really, doesn't it? Yeah. Thinking about what other things, I suppose, might be going on for this person in front of me that might be underlying some of these difficulties.
Okay, so Alex, I'm going to ask you a question about culture of care. What might feel different for a patient or a staff member on a ward that's adopted culture of care?
That's a good question. I feel like we've almost already described it from what we've been talking about so far. But I don't know whether it's useful for me to kind of step back a little bit and say, what is the culture of care programme in the first place? Yeah. So, culture of care, it's a national initiative that's being led by NHS England. And it came about because NHS England were hearing from people who had been in inpatient settings about their experiences and from their families, and that the experience was not as good as we would like it to be across the NHS. And that it was particularly bad for some groups of people over others. So autistic people and people from the global majority in particular were having bad experiences of either very delayed discharges or restrictive practices, which meant that, they and their families were saying this is not good enough. So NHS England brought together a big group of people to co-produce some new standards. So they brought together people with lived experience, families, advocates, professionals, service providers, academics. They brought this big group of people together to say, what would a good inpatient experience look like? And they put together these 12 standards. And at the heart of those standards was the expectation that all inpatient care should be trauma-informed, autism-informed, anti-racist, and that everything should be done in co-production with people with lived experience. So that's kind of where it started. So then over the last 2 years, up and down the country, trusts have been trying to implement these standards across various wards with a kind of a set of pilot wards. And Humber has had a number of wards taking part. And I think that we have made a load of progress. In fact, if we look at the data on the kind of experiences that people have been having on those pilot wards, we know that we've been making a difference, although we've still got some way to go. And we're now working on trying to build those standards into all of our inpatient services. So in terms of what would people feel to be different, I think Nikki articulated it really well at the beginning in terms of the trauma-informed aspect. So one of the standards of the culture of care is that we are needs driven and not diagnostically led, and that we ask people what's going on for them in their life and what have they lived through and how is that influencing how they're experiencing the world now, what they need help with, and why they're presenting for some extra help. Because mental health, it's not simple, is it? It's not like you've been diagnosed with depression, therefore we know that you need 10 days inpatient care and a course of antidepressants and then you'll be better. We know it's just not as simple as that. So I think on one of our culture of care wards, I hope that what people will experience is staff that will welcome them with the question of, where have you been and what do you need? And let's hear about from your point of view what your needs are and how we can work with you kind of to co-produce your care package. And the other thing that I think Nikki's already talked about to a degree was the relationship bit. That on a culture of care ward, we will really see relationships to be the kind of the central aspect of things. So that relationship is the way that we can help people feel safe, that we can help them manage difficult feelings, and it's the relationship through which we start to unpick what's been going on and what somebody needs help with, and that we really privilege and value that, and that's what we encourage of our staff teams, that it is spending the time with people that is the work. It's not about something else that happens magically while somebody's on an inpatient ward. It is those relationships that help make things better. Which sounds really easy, doesn't it? And it's not as easy as it might sound, because for our staff, working with people day in, day out who are very distressed and emotionally need an awful lot of support is hard work. I think if we think of anybody in our lives who we've supported through a difficult time, it takes a lot from us, doesn't it? So that's tricky for our staff teams. So what we have to do as an organisation is provide that practical and emotional support for our staff so that they're enabled to do the difficult work that we need them to do for the patients who come into our inpatient wards. So maybe that's one of the things that also patients might feel to be different, would be about how much time our staff spend doing things like reflective practice and in supervision and in training and in learning together. They might notice that within the wards that looks a bit different.
I feel like we've talked quite a lot about the trauma-informed aspects of the programme, but I wanted to dig into a bit more about the autism-friendly and the anti-racist aspects. Yeah. How do they manifest, say, on a ward, and how people would experience the
ward? Well, in terms of, I guess, the autism-informed bit is partly about environments and partly understanding that people who have got different sensory experiences might need environments that speak to those needs to a degree. So having spaces that people can control, maybe the lighting, have some control over the noise environment that they're in, so that they don't feel overwhelmed by the sensory stimulation. But kind of beyond that, there's maybe something about neuro-affirming practice, which is saying that we're all a little bit different, and that's cool. And that as a staff team, we want to understand how you tick, so that we can help create a system around you that works. So it's not that you come in and you're different and you need something different, but it's just that we are all different, and that we need to shape services around that.
I think on that point, so I've been involved in the Culture of Care programme as an expert by experience with one of the ward teams at Humber as well. And I have my own experience of accessing inpatient care. And one of the projects that we kind of worked on was around looking at reasonable adjustments for people coming onto the inpatient unit, and thinking about what people needed. And that included things that kind of fit with that kind of autism-informed lens. So asking about sensory preferences, communication needs, things like that. And I think what we realised was that questionnaire would be useful for everybody as well. So yes, there's definitely that focus on people with kind of identified kind of neurodiversity, but actually asking everybody should be part of our kind of standard practice. Asking people about their preferences is just a really useful thing to do right at the beginning of that stay, to make sure that we're meeting people's needs and working in a way that kind of suits them, which I guess comes back to Alex's point about kind of being needs led.
Yeah.
I think that's really important.
And it's worth mentioning, isn't it, that it is time consuming, the co-production side, the working, seeking out people with lived experience and then bringing it all together. But it's a worthy move to get a service that's right for people, because as you talked in the opening of the session, you've got a wide group of people, but if you get inclusion and you get access right for one, there's a good chance you're going to get it right for more people. And then it's just about tweaking that over time, isn't it, as you work? And we're all open to that learning culture around things, because we know we may put something in place that doesn't quite hit the mark, doesn't quite get it right. But when we work with a colleague at the co-production side of things, we can learn about that. And we've talked, I think, all of us at some point in the past around learning culture, learning from what we've done, and then adapting and applying that. And so I think it's so important, but it is a time-consuming part of the role, but ultimately the thing that makes it different compared to other initiatives that have been tried in the past.
I think co-production has been one of the really kind of central themes of the culture of care work generally. And I think involving people with lived experience, as you say, does take that little bit more time, and actually the insights you gain from that are huge. I think if we're thinking along the kind of, trauma-informed, autism-informed, anti-racist, those kind of guiding principles, asking people that have been affected by those kind of issues about their experiences, about their views, their preferences, and involving them in making the changes is going to make things better for everybody.
I think it's a really important aspect of this work. The second part of my question was around anti-racism, and I think for me, obviously, that I'm very white. That's not something that I've experienced. So, without actually talking to people who've maybe experienced discrimination, stigma, there's feelings of othering, it would be very difficult for me to design a response to it. I don't know, John. I know you work on anti-racism and the patient care and race equality frameworks. I didn't know if you wanted to comment on some of the things from that programme.
Absolutely, because otherwise you may always be from a position of best intentions, and you think of an idea, you talk in your groups, and as a white man, I've never experienced racism. So what we do, as you say, is involve those staff, marginalised staff, our ethnically diverse staff who have experienced that, because they're the ones who will be able to sit there and say, in my experience, that's not going to work. Try this. And that's where you learn really invaluable things around how racism manifests itself. It's rarely, in this day and age, overt. It's a series of things over time, microaggressions. You learn that from involving those people, as we say, with lived experience of racism. And that's fundamentally at the heart of the PCREFT, is around that. And most of the anti-racism work is about listening to our staff, listening to our patients who've experienced that, and involving them in the core of that design work to improve it. As I say, otherwise it just becomes best intentions that may or may not work, and that's not good enough. For our patients and our staff, we need to have outcomes that reduce racism effectively and not tokenistically.
While we're on that topic, there is a question on here for you about this. I've just got the piece of paper, so I'm going to carry on. So it's, how do discrimination and inequality link to trauma, and what does that mean for my role? I guess all of our roles.
So effectively, discrimination in its own right is a form of inequality. But what we do know is that intersectionality means that people may have multiple inequalities coming in. We've had conversations past about health inequalities, whether that be digital poverty, link that in with a disability, and then you've got that intersectionality of a number of things. And then to be discriminated in a service, we know that trans colleagues or LGBT patients have statistically worse outcomes in attending NHS services and things like that. So it can manifest itself in many ways. And really, ultimately, like a lot of the conversations have gone, it's about listening to people, but listening to people, not listening to people who have good intentions, listening to people with lived experience, and that idea of people bringing people in to help come to a solution. And but ultimately, as you mentioned about in our roles, and we all have different levels of contact with patients or staff or the public, and it's about I think Nikki articulated so well at the top of the meeting, but it's about listening. Fundamentally, an attitude from day one that we're going to listen, but also then having that empathy around people, and also parking your own unconscious bias or conscious bias around certain things, because stereotypes, assumptions and stigma, they destroy trauma-informed care. You need to park them, listen to people, take on board what they're saying, and hopefully collaboratively work with people, as we say, which is what all of these sort of functions are, in around making sure that when you have interaction with other staff or with patients, and it can often be in challenging situations as well, that we understand. I mean, we mentioned about avoidable harm in investigations and things like that. We can still be trauma informed when working with staff and having challenging and difficult conversations.
I think that point, sorry, I was just going to say about kind of not assuming and leaving judgments behind. I think it's really important from kind of a trauma-informed care perspective generally. And I think almost kind of coming back to the point I made at the beginning about everyone's been through different kind of experiences in their life, but we're all kind of different people because of that. Yeah. And I think even if you presented with two people that have maybe had quite similar experiences, it's not assuming that you know how one person's going to react compared to the other because of those experiences. I think not assuming, not judging, and letting someone tell you in their own words is really important in terms of understanding someone's story and kind of how that impacts on them.
Absolutely, because that's where that assumption comes in. And I've seen it, and I've had conversations with managers where they may sit and say, oh, this individual has a certain condition, and they'll just assume that another person had a similar condition, therefore they'll treat it, oh, give them more time. No, why don't you speak to the individual and find out, about how they prefer to operate?
We often say, don't we, in trauma-informed care, it's not the thing that happened, but it's the sense that somebody made of it.
Yeah.
Which is why no two experiences are exactly the same, is it? People will take different things from what happened and need different things in response to that.
Yeah. And I think that point you said about asking that person as well what they need, I think is, again, really fundamental. So not making assumptions about what you think someone might need to feel safe or to feel in control or to feel comfortable. I think it's asking that person, isn't it? In the same way that we're asking them, what happened to you and what sense did you make from that? And how is that impacting on you in the present? I think it's all really important, just that person as the expert in their own experience, and that being something really valuable to ask about and be curious about.
I find it really interesting when you think about trauma-informed and health inequalities. When we talk about trauma-informed, we often talk very strongly about this individual experience, and you absolutely agree with everything that you said there. But the way we talk about health inequalities, we often use a lot of public health data. So then we start looking at big groups of people and some of those systematic differences. Now, I'm kind of reflecting on how the two come together. So we know that statistically, people who come from more deprived neighbourhoods, who live in poverty, who've got experience of stigma and discrimination, are less likely to access the services they need. Well, hang on, take a step back. More likely to suffer from ill health in the first place, less likely to access the services at an early point. Once they're in services, they're less likely to follow the treatment through to the end and less likely to get decent outcomes. So you've got this massive drop-off of how effectively people can be as healthy as they could be. And the individual reasons for all of those will be, as you say, individual and very personal to that person. But by looking at it from a statistical point of view, it does actually help us realise the scale of an issue and where we need to start looking for some of those challenges and some of the questions we need to start asking people. And just thinking about, well, within our population that we support, there will be people who are really struggling to engage with our services and are struggling with their health and are struggling with their conditions of living that are surrounding them. And I think it really does just kind of help us to shape and frame that, even though when we are actually in that one-to-one relationship, not one person who lives in poverty is not going to have the same experience as another person who lives in poverty or who's experienced racism.
And I guess some of that ties back into what Alex was saying about the kind of guiding principles for culture of care. Like they're obviously based on kind of evidence and the kind of research that's been done around certain populations. So the guiding principles being kind of autism-informed, anti-racist and trauma-informed are in recognition of kind of those broader groups of people and how much poorer their kind of outcomes and experiences are when accessing inpatient care. So I think you're right, it's really important to kind of consider those broader kind of groups and that population kind of health data and then bring it down to that kind of individual level in practice as well.
There can be some shared experiences across communities, can't there?
Definitely.
So I guess particularly when we think about the anti-racist work, that people from the global majority might have some shared experiences of like all those small microaggressions, the day-to-day racism that they may experience, and that kind of multi-generational experience of racism, which then might impact on, I don't know, people's sense of whether or not, like erode a sense of trust in other people. I don't know whether I can walk into a situation and whether I'm going to be okay here or not, and that must have a massive impact. So
that generational piece you mentioned is really important as well, because you see it when it impacted in race inequality a lot, because of that generational feedback to people coming into who need to access our services. And we know that there are certain demographics who are less likely to access our services. The highest of those, for example, could be, certainly people who are transitioning, LGBT community, but also, we look at some of those closed cultures who may not even recognise mental health as a community, as something that is real, for want of a better phrase. And that's where a lot of our outreach work, sort of works well to try and break down those barriers, which are very systemic, and encourage people in that early access to our services.
I think kind of generational trauma is something that kind of ties in there as well. I think if we're thinking about kind of being trauma-informed more generally, we've got to kind of bear in mind that kind of risk of generational or kind of intergenerational trauma as well, and how that impacts on people. It's not just necessarily their kind of own experiences of things that have happened to them. There's that impact from that generational perspective as well.
And you have the impact on whole communities in that sense. I think about some of the communities that we work with, particularly in places like Hull or Bridlington, where we've got some very deprived neighbourhoods who've been sort of felt uninvested in, unsupported, overlooked for quite a long time. So then there is some of that distrust of public services when people come in and make big promises. Well, people have come in and made big promises before, and people in some of those communities have felt very let down and excluded. And I think recognising that when people come into our services is quite important, that there is a particular experience within some of those neighbourhoods, but also great resilience of the kind of the people within those neighbourhoods supporting each other and having a very strong sense of the community and a very strong sense of pride in that community as well.
We have to watch out sometimes, don't we? There's services that don't come with a certain kind of arrogance that we know best and we know what the solution is. Yeah. And that's when it comes back to the co-production, isn't it? It's about connecting with people and communities to say, where are you at?
What does your community mean to you? What strength does it give you?
Absolutely. And can we help? Is there anything that we can help with?
Yeah, that point about just being equal with people as well. I think, you're right, not coming in as the kind of authority on things and kind of balancing out that level of power, treating people as equals and as people and as experts in their own experiences and learning from them, as well as kind of sharing that learning back.
I was just thinking, starting from that point as well, of that perhaps generational experience of services not always being trustworthy, and that other people are not always great at helping. So we need to start from a position of, people who might not feel that it's worth investing any time in us as services. And so we need to kind of win that trust in the first place, and that is by working with people on that equal pegging.
I liked what Nikki said about power, because I think trauma-informed care brings that balance back up. If we're doing it right, then we're in our communities. We're listening to how the community wants us to approach, but we're listening to the individual when we're providing care. And I think that balancing out is a good sort of visual
it
for
is,
trauma-informed care.
But I think there's a kind of paternalistic stereotype of a white, middle-aged, middle-class doctor in a white coat with a stethoscope who knows how to fix you and knows all the answers and therefore has all the power. And I think it's quite important within healthcare, particularly because it comes from that background and that model, to have a lot of modesty and humility and recognising that we don't have all the answers and that actually the patient, the service user, the person that we're supporting has a lot of insight and knowledge about what is going to work for them.
I think it's also recognising that as services we can cause harm as well. I think particularly if I think about kind of inpatient services, a lot of people, the vast majority I imagine coming in may have already experienced trauma or kind of significant life events that impact. But I think there's that huge aspect of kind of inpatient care itself being quite a traumatising environment. And I think we hugely run the risk of re-traumatising people or causing new harm as well if we don't kind of fully understand and support people in a way that's helpful for them.
Which I think is partly why the trauma-informed is such a big part of the culture of care. It's appreciating that when people come into an inpatient service, they are probably at their most vulnerable and probably often aren't coming because it's their first choice. They're not saying, please, can I come and book in some time at the inpatient service? And the whole system is very inherently got some very difficult power dynamics in it. People might be sectioned under the Mental Health Act, so legally some of their rights to make choices have gone. So we need to work very consciously to try and level that playing field and reduce some of those power imbalances and to work alongside people. So it needs to be a real conscious effort to work on that.
Yeah, I think if you think about the fact that a lot of people that may have experienced trauma have probably had choices taken away from them. Obviously,
Absolutely.
As you say, coming into inpatient settings where you do often have your choices taken away from you around kind of receiving that care. I think that's really difficult. So I think almost something that people can do that kind of supports being trauma informed is offering choices wherever possible, even if that's really simple things. I think back to kind of my own experiences and even being offered really simple choices, like do you want a cup of tea or a cup of coffee, gives you that little bit of a sense of control back in a situation that's very out of control, and can almost help kind of readdress some of that balance around bigger choices being taken out of your control.
So a question about health inequalities then. How can practitioners know the sentence doesn't make any reading sense?
Shall I have a look?
Yeah.
What can practitioners do? Do you want to?
Yeah, I'll try again.
We can edit this bit out.
On the top. What can practitioners do to support clients who are struggling with poverty and other social inequalities?
Yeah, I think we've talked quite a bit about, in general terms, people's circumstances, but I think this is interesting to focus specifically on poverty. And I think it starts from some of the things we've been talking about already, which is recognising, having that curiosity and an understanding that the person that you're working with might come from a situation where they are living in poverty. And that can have quite a lot of implications for their ability to engage with treatment. So they might be struggling physically to get there due to transport, due to not being able to take time off work if you're in a 0 hours contract. They might have a lot of stresses around them associated with maybe poor housing, insecure work, financial insecurity, and all that's going to impact on their ability to engage with our services and to get the best out of it. Because to be quite honest, it might not be the immediate priority for people that day. I mean, you talk about people who are homeless, and people who are homeless will tell you, well, you know what, my priority is getting through the day safely. My priority is not working on what's going to happen to my health in 5 years' time. So I think seeing people in that context is really important. And there are quite a lot of practical things that people can do to help. So we've started putting together information for staff around, where to signpost people if they're in insecure housing. We're linking up with Citizens Advice Bureau to get people better access to debt and financial advice. So there's lots of practical things that we can do. And I think that we have a duty of care to do that for the people that we support, even though they've come in with a mental illness, or they've come into one of our community services with a physical healthcare problem. as I've said before, if they've got these wider circumstances and conditions of living around them that are negatively impacting on their health, we can't get them better without trying to support them with those wider issues. So I think it is really important that we do recognise the challenges that people are having in that respect, and get them the support they need where we can do that. I mean, it's not our role to go and apply for benefits for somebody, for example, or to start negotiating with council housing teams, but there are organisations that do specialise in doing that, and the more we can link in and tie people into those wider sources of support within the community, the better, and it helps us to do our job, and it helps the people that we support to get better outcome.
I think you made a really interesting point about not assuming that we know kind of what somebody wants to focus on. Yeah. And actually, again, comes back to that kind of principle of just talking to people, asking their opinions on what's the most important thing for them to work on. And I think that's a really important kind of takeaway of not assuming that you know best about what someone's priority might be without asking them about what their priority is.
Yeah. I mean, I've spoken to clinicians who work within our teams, and they've said things like, well, I couldn't talk to the person about the issue of going into the particular past trauma that perhaps that was impacting them, that caused them to get into the situation of distress they were in, because all they could focus on was, I'm going to lose my house in a week's time, and I need to focus on that, and I can't talk to you about anything else because this is an overwhelming life circumstance that I need to deal with right now.
Which makes a huge amount of sense, doesn't it? Like, of course, if you're in insecure housing and you're worried about losing the place that you're living, it doesn't make sense that you'd want to focus on something else. That's going to be a priority. So I think it's just about, again, coming back to that kind of curiosity and just that conversation with people, listening to them and what's their priority in that moment.
And being safe is always the number one at any point in time, isn't it? So if you haven't got a safe place to sleep at night, that has got to be the thing that we help people with first before we start thinking about anything else that's going on for them.
And having that understanding of the wider determinants of sort of health and health inequalities is trauma-informed itself, isn't it? Because we're understanding the communities that we're serving, and then not making assumptions around, because we know that there's certain areas of poverty, for example, will give you higher rates of people accessing mental health services. And in knowing that in advance, we remove the assumption that someone is going to go back to work because there may not be work, or the assumption that they've got a home to go to, you know, and then we can look at signposting to that support of other agencies outside of the organisation who can help with those sort of initiatives to support people. So I think that in itself, just having a better understanding of the why in our local communities and the areas that we serve, is trauma-informed in its own right, you know, getting to know the why. So when we do meet that individual, we can already think about some of those background challenges. And as I mentioned about intersectionality, you know, it all comes together to present that individual in front of you who is a very complex person before they even start to discuss what the help they need.
It also helps us to start thinking about what the future looks like for the people that we're trying to support, and what kind of protective factors we can help them to get in place. And that might be something like employment. You know, we know there's a really strong link between employment and better mental and physical health. So somebody who's in secure employment is more likely to be healthy, to feel secure. And if part of somebody's recovery is accessing employment, then that's something that we should be thinking about as part of their recovery journey. And it might not be directly something that we provide, although we do have teams that do employment support. But it might be about how we think about that person's future aspirations and what recovery looks like for them in the widest sense, not just in being physically, mentally healthy, but what their life looks like at the end of it.
I wonder if there's something there as well about helping people have hope for the future, because quite often when people come into our services, they're struggling with that sense of having a positive future to work towards.
I think in my experience, that's been like a key factor for me in kind of my own journey with recovery. So I did a therapy where they talk about life worth living goals. So what things in your life would make it feel like it was worth living, with that recognition that a lot of people that kind of really struggle and have experiences of kind of complex trauma might not feel like their life is worth living in that moment. So I think it's really important to have those conversations with people and do that kind of inspiring of hope in people for what they want from the future, what they want their lives to look like.
And then working on the priorities that they've got right now, be that housing, employment, relationships. Yeah. I was just thinking we have got an example of a project that's going on one of the Culture of Care wards, haven't we? Which is that you've introduced us to the Citizens Advice Bureau, and we're hoping to set up some regular kind of drop-in clinics within one of the wards, one of our assessment wards, where there's quite a high turnover and people don't stay for very long. So it's really important that they get every opportunity to work with other agencies to try and sort out things that are important to them, like benefits and housing. So we're looking forward to that.
Yeah, I think that's a really good step forward for us. And I think it's often about working with partnerships. So it's working in partnership with the people we support and with the communities that they work within, and within the voluntary sector organisations that are around them. Because people aren't just no man's an island, the classic phrase. But we need to think about people in that wider context and what we do, but also what other organisations do as well. We talk a lot about organisations working as anchor institutions, where they're really connected into the communities, but also connected with other organisations that support the same groups. And I think that's an important aspect of what we do in terms of health inequalities, and in terms of that those wider conditions of living and building that safety around people. But I think one thing that I would take away from this is the importance of giving people a sense of hope and aspiration, and a sense that there's a better future that they can work towards for themselves and for their communities, that address all those sort of wider themes that we've been talking about.
I think that's really important, because I think if we think about some of the people that we work with that come to us at points of really high levels of distress, sometimes it's really hard to hold on to that hope for yourself or be able to do that. So I think if we can have a role in being able to do that for other people, that's hugely valuable.